I'm Antonio Jimenez. I'm a transplant attending at the University of Miami, the Sylvester Comprehensive Cancer Center. And I'll be discussing our analysis. It's a CIBMTR analysis that we did evaluating the prognostic impact of modified ELN classification. So the idea was to see if the newest ELN classification, the classification from 2017, provided prognostic stratification in the transplant setting, the same way it does after induction therapy. We had an initial cohort of over 4,000 patients, but to better evaluate the impact of genetics, we restricted the study to patients in first remission. We excluded patients with active disease. We also excluded patients with incomplete cytogenetic and genetic data, and ultimately end up with a cohort of 2,289 patients, okay? So these are all patients with acute myeloid leukemia, comprehensive molecular and cytogenetic data in CR1, okay? And we utilize a modified ELN classification. And essentially what that modification meant was registry databases, including CIBMTR, don't have, or most of them don't have, comprehensive information about FLT3 allelic ratio. So that was removed from that classification. Patients were just stratified as it was just a yes or no question, which is what most centers report to the CIBMTR. And then the second thing was we did not include the presence of biallelic or monoallelic CBPA. So patients were just stratified on the basis, again, a yes or no question, wild type or CBPA. So with those modifications, without spending too much detail on that, we essentially came up with three groups, favorable, intermediate, and adverse. 181 patients were favorable, close to 1,200 patients intermediate, and 923 adverse. And what we found was our main idea was to see that there was prognostic stratification. We found that there were significant differences in relapse, disease-free survival, and overall survival among all these three groups. But we also found that favorable and intermediate were really comparable. So when we performed multivariate analysis, there were really no differences in disease-free survival and relapse for these groups, so they were combined. So while there was prognostic stratification, it occurred in a different pattern than what it happens in induction. We really identified two groups. I will say intermediate favorable group, and for those patients, disease-free survival was close to 60%. And we found an unfavorable group, and that number was about like 45% with a relapse rate of close to 40%. So we also identified, I will say, a very poor risk group, which were patients with monosomy 5 and monosomy 7. And this is in line with reports that others have published already, including the CIBMTR. The most common abnormality in that group was monosomy 7, and we found that patients with -7, -5 had the worst outcomes, with almost half patients relapsing. And remember, these are patients transplanted in CR1, most of these with MRD negative disease, and a fair number of these patients receiving myeloablation. The impact of ELN was independent of conditioning intensity of MRD status. And, you know, as other series have also reported, other factors that independently predicted outcomes were MRD status, conditioning intensity, and AML onset. The main conclusion was that there was prognostic stratification, but we were able to identify two groups. One of the potential explanations, and of course this retrospective study doesn't answer that question, is that your quote-unquote favorable group in a transplant study is very different to a favorable group in an induction study. You know, when we went back and looked at our favorable group, many of these patients had a higher incidence of MRD positive disease at the time of transplant, or failed induction, or extramedullary disease, or many other risk factors that are not necessarily captured in a registry analysis. So in reality, you know, it's hard to really find a robust, favorable cohort in a transplant patient, because these patients were to transplant for a reason. But I think the important message is prognostic stratification is possible. We identified two groups, and there continues to be a group that even when transplanted in CR, first CR, with MRD negative disease and receiving myeloablation, they continue to have poor outcomes. So these are the patients that we need to continue looking at strategies to improve post-transplant outcomes and minimize relapse.